Our next topic will be in the surgical treatment of diabetic macular edema, and will be presented by Dr. Walid Al Turki. Dr. Walid Al Turki is highly active retinal surgeon at Al Magrabi Hospital. He is Saudi Retina Group board members, and I would like to say good luck for your talk.
Okay. I'd like to first thank the organizing committee for inviting me to speak today, specifically Dr. Saad Wahib and Dr. Abdullah Al-Qahtani, who insisted that I should be involved in this conference a few months ago. I'm a little bit on the lazy side, but thank you guys for inviting me. What I'm going to be talking about in the next, hopefully, 15 minutes about the surgical management of refractory diabetic macular edema. Before I just start this talk, I was trained 26 years ago, in 1990, in New Orleans by Dr. Ghulam Payman. And at that time, Ghulam was thought to be a little bit on the aggressive side. And we always most of the time, approached primary rhigmatogenous retinal detachment at that time with vitrectomy. People thought really that we were crazy at that time, doing vitrectomy on primary retinal detachments, when most of everybody was doing scleral buckling. Over the years, things have changed. And now, most of the retina specialists in the world approach rhigmatogenous retinal detachments with vitrectomy. Less and less buckling procedures were done, and with good results. I was really worried at that time because I didn't really was very well trained in scleral buckling for primary retinal detachment, but I did quite well vitrectomy. Now, talking about diabetic macular edema, 20 years ago, this would be like crazy. Why would you talk about diabetic macular edema with doing surgery on these cases? But with the years, the advent of small caliber, high cutting surgical instruments, and the anti-VEGF treatment made us really start thinking that there are cases that are resistant to laser and anti-VEGF that should be approached with surgery, with excellent results. Diabetic retinopathy with clinically significant diabetic macular edema, as you know, is the leading cause of blindness among the working age adults, and about 50% of eyes will lose vision, two or more lines. Obviously, as the previous speakers have talked about, the incidence of DME can be reduced with systemic control of blood sugar, hypertension, hypercholesterolemia, but really the ophthalmic treatment of DME is mandatory. There is availability of therapeutic agents like anti-VEGF, lasers, steroids, but really refractory or resistant diabetic macular edema continues to challenge retina specialists. You keep injecting and no response. There is a small subset of patients that would benefit from surgical treatment of DME. I'm not going to go over focal diabetic macular edema is treated by laser, diffuse diabetic macular edema. This is something also very interesting. Before, years ago, for diffuse diabetic macular edema, we used to do grid laser and modified grid laser a lot. And I was never convinced of doing, why would you do grid laser for something, keep hammering the RPE when you don't know where to go? So there had to be something better. And the anti-VEGF treatment came and it's giving pretty good results. But there's the diffuse diabetic macular edema with the tractional and epimacular component that one should think of. Focal is focal laser, diffuse diabetic macular edema. As a matter of fact, I stopped totally doing grid laser for diffuse diabetic macular edema. I only use anti-VEGF. And there's the diffuse diabetic macular edema with tractional forces. We can use anti-VEGF, but have to think of surgery. So when evaluating an eye for surgical intervention, one should classify diabetic macular edema as focal or diffuse, but also on the status of the vitreous and the vitreomacular interface. Obviously, it's the vitreomacular interface is best evaluated by fundoscopic examination and OCT. The surgical classification of DME, if you have DME with abnormal vitreomacular adhesions or proliferation, post-vitrectomy taught ILM, and recalcitrant DME without abnormal vitreomacular adhesion. You have resistant diabetic macular edema, and you don't see epimacular membranes. So I'm going to go over 4 cases and discuss how they went in the surgical intervention in these cases. So case 1, a patient came with a preoperative vision of 2400. There is cases that are straightforward surgical diabetic macular edema, this is one of them. It's a tractional diabetic macular edema with had asteroid hyalosis with it. This patient underwent phacoemulsification with intraocular lens implantation, vitrectomy, internal limiting membrane peeling, obviously posterior hyaloid stripping before the ILM, and anti-VEGF. This is the preoperative OCT when the patient presented initially. Obviously, I would not do any anti-VEGF treatment in a case like this, because this might turn out to convert into a macular hole. So this is a straightforward tractional diabetic macular edema, patient with 2400 vision. So what we did, okay. How do you do? Excuse me? Oh, it's okay. It's okay. So we initially put triamcinolone, stripping the posterior hyaloid. You'll see it here. Posterior hyaloid is stripped. Vitrectomy is done. This patient, remember, he has a tractional membrane. So we stain the ILM. And you will see that I will leave the exact element of the ILM on the fovea itself, so so it does not create a macular hole. So we're removing the ILM around with the membrane, and we left the center exactly here. So 2 months later, visual acuity in this patient improved from 2400 to 2100. And this is his post-op 2 months later, his post-op OCT. He finds still some cystic spaces. I'm just gonna. Okay, cystic spaces, and this he will need anti-VEGF treatment after that. Now this is his pre-op OCT on the left side, and his post-op OCT on the right side. Case number 2. A patient presented with diffuse diabetic macular edema, had multiple anti-VEGF injections, but persistence and resistance of the diabetic macular edema with the development of a lamellar macular hole. We injected him, he did not improve, and he developed a macular hole. His visual acuity was preoperatively 2400. So then we thought, okay, let's try to do a vitrectomy on this patient. So we did vitrectomy. He was pseudophakic. Did vitrectomy, ILM peeling, and anti-VEGF. This was his pre-op OCT. Actually, a few months earlier, we injected him at that time. I think I've done a mistake here, because there is some element of tractional force here on the fovea itself. This patient would have benefited from a vitrectomy earlier, but I did not. So I injected him at that time, and then he developed a lamellar macular hole, And this is the time when I said, okay, let's try doing vitrectomy on this patient. So we went ahead and did vitrectomy. Okay. Now, very important to remove the posterior hyaloid. We did not stain here, did not do triamcinolone assisted vitrectomy. We removed the posterior hyaloid. Here we stained, put the brilliant blue stain. I use brilliant blue. Some other people would use ICG, but I use brilliant blue, and I find it very, very helpful. And we injected the brilliant blue. Now we're removing the ILM. In diabetic macular edema, unlike macular holes, the ILM sometimes comes into strips. It does not come as a whole. Here it went okay, actually. Okay, so here's the ILM removed. 7 months later in this patient, visual acuity improved to 20/60. This is his post-op OCT. A few months later after the surgery. So on the left side you see his pre-op OCT with a lamellar macular hole that was just immediately pre-op, and on the right side his post-op OCT with improvement of his of the foveal thickness. Case 3, a case of diffuse diabetic macular edema, had multiple anti-VEGF treatment with resistance. Visual acuity was 20/150. So at that time we decided, okay, he's resisting anti-VEGF, still with persistence of his diabetic macular edema. We took him to surgery. We did phaco-IOL vitrectomy, ILM peeling, and anti-VEGF. This was his pre-op OCT, huge edema. Here we stripped the posterior hyaloid and we stained already the ILM. We're using Tano brush actually to create an edge in the ILM, and we use Eckert forceps to remove the ILM. It actually here was not difficult to remove the ILM. It will come as a sheet. Okay. The visual acuity in 6 months later improved to 20/30 from 20/150. This was his post-op OCT. Amazingly, you'll see this on the left side. You'll see his OCT preoperatively. On the right side, with 20/30 vision. This was his post-op OCT. Obviously, much reduction of his diffuse diabetic macular edema, but this patient will continue to have anti-VEGF treatment, and I believe by removing the ILM here, the tractional forces, his diffuse diabetic macular edema will be much less, but with improvement of vision. Last but not least, case 4 actually, it's a patient with diffuse diabetic macular edema with tangential epimacular membrane that I'm going to show you now. Had only one injection of anti-VEGF with no response. So I said, I'm not going to keep injecting him. Let's take him to surgery. And visual acuity is 20/80. I would not have done a 20/80 vision eye 20 years ago. But now really when we're more comfortable doing vitrectomy, the small caliber, high cutting rate, instrumentation and everything, vitrectomy is much easier now than we used to do before. So we took him to surgery at 20/80 vision, underwent phaco-IOL vitrectomy, ILM peeling, and anti-VEGF. This was his preoperative preoperative OCT, and you'll see a very fine, a very fine epimacular membrane here. Okay, here we're injecting the brilliant blue stain, and here actually, as a matter of fact, I stained, removed the posterior hyaloid. It came as a whole. Then we restained again. We're using the Tano brush to create an edge for the ILM. So the visual acuity of this patient, who started with 20/80 vision, went to 20/30 in 7 months. This was his post-op OCT, pre-op OCT on the left side, much reduction of his diffuse diabetic macular edema on the right side, but this patient will continue to have anti-VEGF treatment after that, because we remove the tangential forces of the of his macular edema. So, in conclusion, diabetic macular edema has to be addressed in different modalities, but you have to start thinking about, or not start, actually think about surgery and removal of the tangential forces. Once you keep injecting and there's no improvement, and no improvement in vision, you have to start thinking of that surgery really has a role in the management of diffuse diabetic macular edema. Thank you very much.